Hello, everyone, and welcome to today's webinar, Preterm Labor and Rupture of Membrane Management, Diagnosis, and Prevention in Pregnancy. I am Jennifer Woods of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by QIAGEN. To learn more, visit QIAGEN.com. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Tanja Nikolova, MD, MSc, PhD, Department of Gynecology, Obstetrics, and Reproductive Medicine, Academic Teaching Hospital of the University of Heidelberg. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Nikolova, you may now begin your presentation.
Thank you very much for the nice introduction. I'm Tanja Nikolova from Klinikum Mittelbaden in Baden-Baden. I'm very happy today to talk about the most challenging problem in our everyday practice, preterm labor and rupture of membrane management, diagnosis, and prevention in pregnancy. Today's agenda is a bit 4 questions. The first one, which we should answer today, is what is the current protocol for identifying patients with threatened preterm labor? Is there a change in algorithm or patient care with the ongoing pandemic? The second one, what role do biomarkers play and what is the difference between them? The third one, how can a better diagnostic method impact management of preterm labor and rupture of membrane patients? And the last one, what role do biomarkers play in the management of suspected rupture of fetal membranes? What are the recommendations amidst the pandemic? We will start with the first one. And we, from our practice, know that clinical symptoms and biophysical methods are not sufficient to make a treatment decision because of their very low positive predictive value. We know that the presence of clinical symptoms does not necessarily indicate an imminent delivery. Here is presented a typical European protocol for diagnosis of patients with signs and symptoms of preterm labor. When a patient comes with one symptom or many of them, the first thing which we do is a transvaginal ultrasound. If the cervical length is less than 25 millimeters, the patient is admitted for 48 hours. If the contractions are active, we begin with tocolysis and corticosteroids for fetal lung maturations. If no delivery occurs, patient is checked again after 48 hours. If the cervix is dynamic and there are still regular contractions, the patient is kept longer for observation. If no delivery occurs, patient is checked again after 48 hours. If she is stable, the cervical length is not shorter, and the symptoms subside, the patient could be discharged. If with transvaginal ultrasound, the cervical length is detected to be more than 25 millimeters, and there are no active contractions, nowadays the patient is discharged. If active contractions, patient is observed for 24 hours and examined again. WHO has issued guidance for management of pregnant women in COVID-19 pandemic. What we should talk to our patient, which information should be shared with the patients are the following. If you are infected with COVID-19, you are still most likely to have no symptoms or a mild illness from which you will make a full recovery. If you develop more severe symptoms or your recovery is delayed, this may be a sign that you are developing a more significant chest infection that requires enhanced care. You should contact your maternity care team immediately. There may be a need to reduce the number of antenatal visits you have. However, do not reduce your number of visits without agreeing first with your maternity team. And here are shown the guidance for obstetrical care providers during COVID-19 pandemic. If a woman meets criteria for COVID-19 testing, she should be tested. Until test results are available, she should be treated as though she has confirmed COVID-19. Do not delay obstetric management in order to test for COVID-19. Elective procedures like induction of labor for indications that are not strictly necessary, routine growth scans not for strict guidance-based indications, and routine investigations should be reduced to minimum at discretion of care provider. If ultrasound equipment is used, it should be decontaminated after use. As obstetricians, we have a very important role in this corona time. On one side, to reduce exposure of pregnant women with telemedicine. On the other side, to provide timely and adequate care for patients which present with signs and symptoms of preterm labor and preterm rupture of fetal membranes. We came to the second question, so we should answer now: what role do biomarkers play and what is the difference between them in prediction of preterm delivery? What we know from the statistics is the following. Up to 30% of patients presenting with signs and symptoms of threatened preterm labor may be admitted to the hospital. Only 5 to 10% of these patients go on to deliver within 7 days. This results in up to 85% of unnecessary and avoidable admissions. Tocolytic agents, especially beta-mimetics, have several known maternal side effects, including increased risk of maternal palpitations, nausea, tremor, chorioamnionitis, hyperglycemia, and hypokaliemia. Multiple rounds of corticosteroid administration are not recommended due to their association with adverse neonatal side effects, including lower birth weight, smaller head circumference, and shorter height. So a very important question stands in front of all of us obstetricians, and it is: can we more accurately assess patients with signs and symptoms of preterm labor? The timing of antenatal corticosteroids is also very important. There are many published literature which say that optimizing the timing of antenatal corticosteroids can improve outcomes for newborns. But on the other side, 40% increase in mortality is seen in infants given antenatal corticosteroids more than 7 days before birth, compared with an interval of 1 to 7 days. The risk of infant mortality is doubled with shorter or longer administration to birth intervals of antenatal corticosteroids and birth than 1 to 7 days. Statistically significant increase in risk of intubation is seen in neonates born at 8 to 14 days of antenatal corticosteroid administration, compared with intervals of 1 to 7 days. Higher odds of mortality and necrotizing enterocolitis is associated with administration of antenatal corticosteroids when given more than 7 days before birth. We have performed a prospective observational study, which was multicentric study and was lasted for 3 years. From these studies, what we get from our statistics is that current protocol, when looking at cervical length for less than 25 millimeters, captures about 31% of patients which will deliver in the next 7 days after testing. Patients with a cervical length from 25 to 30 millimeters have a 17% risk of delivering within 7 days, but we currently do not observe them due to limited resources. Approximately 60% of patients fall in an equivocal cervical length range, with cervix for 15 to 30 millimeters long, in which the risk assessment for preterm birth is not conclusive. On this slide, I have presented our 203 investigated patients, and they are stratified according to the cervical length in cervix 10 to 15 millimeter long, 15 to 20 millimeter long, 20 to 25, 25 to 30 millimeters, 30 to 35, and more than 35 millimeters. There is a curve, and above this curve, there are numbers in percentage which show how many of the patients in this group have delivered in the next 7 days. Patients with shortest cervix, 100% of them delivered, all of them. Patients with cervical length 15 to 20 millimeters, 55% of them delivered. 20 to 25%, 21% of them delivered. And these are the patients which are actually in the current protocol, patients with less than 25 millimeters, not the others. What we have found out in our study as a huge problem was the group of patients with cervical length from 25 to 30 millimeters. They were 29% of our recruited population, and they delivered, 17% of this group delivered in the next 7 days. Then we ask ourselves if biomarkers can optimize identification of patients at risk of delivery within 7 days of assessment in order not to miss this 17% of patients with cervical length more than 25 millimeters. Today at the market, there are 3 biomarkers available which are used for the prediction of preterm delivery. Fetal fibronectin is a glue-like protein that holds the developing baby in the womb. Phosphorylated insulin-like growth factor binding protein 1 is found in high concentration in the choriodecidual interface. Placental alpha microglobulin 1, PMG1, is a placental protein that is released into the amniotic cavity. As a result, the release of fetal fibronectin and phosphorylated insulin-like growth factor binding protein 1 into the vaginal cavity can be caused by digital examination or manipulation of the cervix. Because PMG1 is not known to be found in the extracellular matrix, it may not be as easily released due to such manipulation. The PAR2Sure test is the market name of PMG1 and is a protein which is found in very high concentration in amniotic fluid, 2000 to 25,000 nanogram per milliliter, and it could be also found in very low concentration in normal vaginal discharge. Recent clinical studies have demonstrated a strong correlation between a positive PMG1 test and imminent delivery in patients presenting with threatened preterm labor and intact membranes. A publication from 2012 from Lee and Romero postulated 2 possible explanations for the presence of PMG1 in cases of threatened preterm labor. The first postulation is the transudation of PMG1 through chorioamniotic pores in fetal membranes could occur during uterine contractions. And the second one is the degradation of extracellular matrix of fetal membranes could occur due to inflammatory process of labor and or infection. There are many studies which are performed in the last 10 years all over the world across different nationalities of patients. I have presented here the most important, and I have divided them in 3 groups. Low risk group with number of events, number of preterm deliveries in the next 7 days of less or equal to 5%, or cervical length more than 3 centimeter. Then the second group is the group with intermediate risk for preterm delivery, where the number of events was 5 to 15%, the cervical length 1.5 to 3 centimeters. And the last 2 are presented by high-risk population with more or equal to 15% of preterm delivery and cervical length of less than 1.5 centimeter. We could see that in all populations, in the all population, the negative predictive value is very high. It's higher than 94%. But the positive predictive value in intermediate risk group and high risk group is also very high, from 50 to 100%. Here is presented a comparative analysis between 2 biomarkers, biochemical markers, PMG1 and fetal fibronectin, and biophysical markers, cervical length, in a population of 2003 patient prospective observational study. We have examined the prediction power of these biomarkers in the next 7 days after recruitment. We have found out a very high negative predictive value for all 3 investigative biomarkers, but the PMG1 appeared to have significantly higher positive predictive value of 76%, which was much higher than the one of fetal fibronectin and cervical length, when the cutoff, as a cutoff, was taken 25 millimeters. This is another population of 328 patients where we have compared the PMG1 versus phosphorylated insulin-like growth factor binding protein 1 versus cervical length. And again, the negative predictive value was high for all of the investigated biomarkers, but the positive predictive value of PMG1 was remarkable, 60% for PMG1. The publication from 2017 from Ravi and collaborators have done a comparison between PMG1, which was qualitatively assessed, versus quantitative fetal fibronectin. And they have done this comparison with 2 different cutoffs for fetal fibronectin, 50 nanograms per milliliter and also 200 nanograms per milliliter, and compare the predictive power of these 3 parameters. But again, PartoSure or PMG1 had significantly higher positive predictive value. I have presented here the systematic review and meta-analysis published by Melchor and collaborators. And this meta-analysis shows that PPV for PMG1 is higher than the one of fetal fibronectin and phosphorylated insulin-like growth factor binding protein 1 within 7 days of testing. The most of the population was with high risk, a number of events more than 15%, and very short cervical length, less than 1.5 centimeter. They have concluded that the use of a highly specific assay like PartoSure in threatened preterm labor may optimize the management of these patients. In this systematic review, it's also reported the area under the curve for all tested biochemicals biomarkers, and PMG1 appeared with highest area under the curve from 0.961 Area under the curve is a measure of how well a parameter can distinguish between two diagnostic groups, diseased and normal. So PMG1 captured the diseased patient very well, very powerful. For a better understanding, for better perception, I have presented the results of this meta-analysis in a table as well. And we could see that the positive predictive value of PMG1 was 76%, negative predictive value 97%, positive likelihood ratio very high, 22.51, negative likelihood ratio low, 0.24, area under the curve as mentioned, 0.961. And the positivity rate of PMG1 was significantly lower than one of the fetal fibronectin and phosphorylated insulin-like growth factor binding protein 1, which means that PMG1 gave a very low number of false positive results. Piriani and collaborator in 2019 also published a meta-analysis. They found out, they showed that the positive likelihood ratio and negative likelihood ratio are consistent for risk assessment within published data. So which biomarker is most useful? Based on the publications comparing PMG1 with fetal fibronectin and phosphorylated insulin-like growth factor binding protein 1, PMG1 seems to be a useful biomarker for prediction of spontaneous delivery within 7 days of testing. The guidelines for the management of spontaneous preterm labor, prepared by the European Association of Perinatal Medicine and published in the Journal of Maternal, Fetal and Neonatal Medicine in 2017, have incorporated PMG1 in diagnosis of patients with signs and symptoms of preterm delivery. Their main points are the following. Bearing in mind the negative predictive value of such test, PartoSure PMG1 fetal fibronectin is negative and cervical length by ultrasound is more than 2.5 cm, we recommend that tocolytic therapy and steroid prophylaxis should be withheld. Bearing in mind the positive predictive value of PartoSure, we recommend that tocolytic therapy and steroid prophylaxis should be administered. With such management, there are benefits to the hospital and benefits to the patient. Benefit to the hospital reduces unnecessary admissions and transfer to neonatal intensive care unit. Cost savings to the hospital, reduction in administering medical management and availability of beds. Benefits to the patients, unnecessary medical intervention, peace of mind, uninterrupted travel plans, employment, less burden on spouse and family. We steadily come to the third question. What should we answer next is how can a better diagnostic method impact the management of preterm labor and rupture of membrane patients? Here is shown a protocol where PMG1 could guide the preterm labor admissions. This protocol is in wide use in Spain and United Arab Emirates. So when a patient presents with signs and symptoms of preterm labor, what is first done is collecting PMG1 from vaginal sample. Then they do digital exam, then they do transvaginal ultrasound for cervical length management, and they do cardiotocography. If they have dynamic uterus and they have cervical changes, and these cervical changes are sufficient, they admit the patient and they treat the patient with tocolytics and corticosteroids. If there are no cervical changes, they guide themselves according to the PartoSure test. With negative tests, they discharge the patient. With positive tests, they keep the patient and they observe the patient. If the cervical changes are insufficient, then cervical length is the one who will decide how the patient will be managed further. With cervical length of more than 25 millimeters in gestational age groups 24 to 31 weeks and more than 15 millimeters in 32 to 34 weeks, the patient could be freely discharged. If the cervical length is less than 25 millimeters and less than 15 millimeters in already mentioned gestational age weeks, again, the guidance is according to the biomarker test result. With positive biomarker tests, the patient will be treated or are treated. With negative tests, the patient are kept for observation and estimation of the situation later. Here is presented a combined PMG1 and cervical length protocol to guide preterm labor admissions, and this protocol is used in most of the European countries nowadays who could afford in their settings the PMG1 biochemical markers. It goes in this way: when patient presents with signs and symptoms of preterm labor, the patient gets diagnosed with transvaginal ultrasound and cervical length is being determined. When the cervix is shorter than 15 millimeters, the patient is admitted, therapy is administered. If the cervical length is more than 30 millimeters and there are contractions more than 4 in 20 minutes, the patient is observed for additional 2 hours. If no cervical changes, she will be discharged. If the cervix is long, more than 30 millimeters, and there are no significant contractions, the patient is discharged immediately. The most problematic group is the group with cervical length 15 to 30 millimeters, where PMG1 helps much. We use this marker in our settings on daily basis. So if we get this positive PMG1 in this group, we admit the patient when we administer therapy. If the test is negative, then the patient gets discharged. Here is presented study publication of Bolotsky and collaborators from 2018. They have compared PMG1 tested alongside with cervical length and cervical length tested alone. And they have assessed the predictive power of these two modalities. Partosure plus cervical length when cutoff is 25 millimeter and cervical length alone when with the same cutoff, 25 millimeter. What they found is a high negative predictive value, but 10 times higher positive predictive value when Partosure is used together with cervical length in the group of patients which have cervical length 15 to 30 millimeters. So the predictive power is pretty higher when we use these two modalities together. The cost of reducing false results. A false positive can result in unnecessary medications, transfers, hospital admissions, and induction. A false negative result, on the other side, can lead to an unwarranted discharge, which could cause lifelong complications and patient litigation. Here is presented visually the reduction in unnecessary admissions when the patients are tested with PMG1 versus fetal fibronectin. These are the results from our study. So we have found out that for every 100 women presenting with signs and symptoms of preterm labor, Partosure produced 18 positives. Of them, 4 were false positive. Fetal fibronectin produced 32 positives. Of them, 23 were false positive. avoiding unnecessary treatment causing maternal and neonatal side effects. When presumed diagnosis of preterm labor has been made, tocolysis is commenced to delay labor, thus allowing time for the administration of a full course of corticosteroids. Current benefit and risk data are insufficient to support routine use of repeat or rescue courses of antenatal corticosteroids in clinical practice. In women who remain at increased risk of preterm birth after receiving an initial course of antenatal corticosteroids, multiple courses are not recommended. Avoiding unnecessary treatments reduces maternal and neonatal side effects. PMG1 has shown to be useful to guide patient therapy. The use of tocolytic agents should be individualized and based on maternal condition, potential side effects, and gestational age. According to Hagen, the high rate of unnecessary use of tocolytics suggests a significant opportunity for patient safety improvements via the combinatory use of PMG1 test and cervical length measurement. And according to Van Holzbeke, based on a positive PMG1 test, in addition to cervical length measurement, unnecessary admissions and drug administration may be reduced by up to 71%. We came now to the third question today. How can a better diagnostic method impact management of preterm labor and rupture of membrane patients? According to the German company, based on DRG and average cost of German calculation hospitals, it's found out that every day a hospital stay of a preterm labor patient can be shortened, results into an up to €369 higher profit for the hospital. And according to Fatkulin and his publication in Journal of Maternal Fetal Neonatal Medicine, a negative Partner-Sure test may be useful to identify patients that can be safely discharged after 24 hours of observation, reducing their length of stay and burden on the hospital resources. In the summary, cervical length measurement is most useful to identify patients for admission and treatment when combined with a biomarker test between 15 and 30 millimeters. PMG1 test has the unique advantage of a very high positive predictive value with a high negative predictive value, leading to new options to improve patient management in multiple clinical situations, and better identification of patients who are at high risk of delivery within 7 days will avoid unnecessary admissions, unnecessary treatments, and transfers. What are the recommendations amidst the pandemic? Latest consideration for labor and delivery from the Society for Maternal Fetal Medicine and the Society for Obstetrics and Anesthesia and Perinatology advise prolonged exposure to high-dose steroids has been associated with worsening of SARS coronavirus patient outcomes in the general population. How this applies to antenatal corticosteroids is still unknown. Until evidence is available, practices could consider adjusting protocols, balancing theoretical maternal risk against the magnitude of known fetal benefits in each clinical circumstances. And the last question, what role do biomarkers play in management of suspected rupture of fetal membranes? What are the recommendations amidst the pandemic? I have already mentioned that PMG1 could be found in healthy women during the whole pregnancy. The concentration is very low, 0.05 to 0.2 nanograms per milliliter. With a threshold of 1 nanogram per milliliter, it's an indication for preterm labor. With a higher threshold of 5 nanograms per milliliter, it's indication for rupture of membranes. And in amniotic fluid, PMG1 is present in very high concentration, 2,000 to 25,000 nanogram per milliliter. On the other side, insulin-like growth factor binding protein 1 is a ubiquitous protein also found in blood and cervicovaginal secretions. Phosphorylated insulin-like growth factor binding protein 1 has multiple isoforms accumulated in the cells of decidua and could make an interference with the accuracy, with their accuracy. This is the algorithm for rupture for patients which come with symptoms and or signs suggestive of preterm rupture of membranes. We initially should decide if really the membranes are ruptured or not. If they're ruptured, then there are contraindications to expectant management, we should deliver the patient promptly. If no contraindications to expectant management, we should simply wait. And then our further management depends on gestational age. In patients which are less than 32 weeks pregnant or 32 to 34 weeks pregnant, corticosteroids, antibiotics, tocolytics are mandatory. Fetal surveillance is also very important. We could offer elective delivery at or after 32 weeks of gestation. It's easier with patients which are more than 34 weeks pregnant. We could offer here elective delivery without any problem. Here are presented traditional methods which are widespread, first-line use, and biomarker tests which are more accurate and easier to use to rule out ruptured membranes. Nitrazine, ferning, pooling are still in use, but they require speculum insertion. And many substances could interfere here. Ultrasound could be also done, but it can only detect low levels of fluid, and it requires expertise and time. Then these methods could be used in combinations. Again, these combinations are complicated and they still do not achieve the needed specificity and sensitivity. Amnio-dye infusion is meant as a gold standard for a rupture of membrane diagnosis, but it's a highly invasive procedure, it's expensive, requires expertise and time. At the moment on the market, there are 4 biomarkers for the diagnosis of membrane ruptures. These are quick check fetal fibronectin, which detect the fetal fibronectin glycoprotein, Amnisure rupture of membrane test, which detects PMG1 glycoprotein, rupture of membrane plus test, which detects both alpha fetoprotein and insulin-like growth factor binding protein 1, and actin-prom, which detects insulin-like growth factor binding protein 1 alone. I analyzed all of them. Amnisure had the highest specificity of 100%, and very high sensitivity of almost 99%. It is intended for detecting leaking amniotic fluid, and it's not affected by semen, by blood, and vaginal infections. What are the recommendations amidst the pandemic? Latest consideration for labor and delivery from the SMFM and SOAP recommend alternative methodologies for evaluation of rupture of membranes could be considered given the potential exposure risk, microscopy and ferning evaluation for women with SARS coronavirus or patients under investigation. I have presented here, I will present here 3 the most relevant studies in the field of membrane rupture diagnosis. The first one is a study published by Sosa and collaborators, which have evaluated the potential of PMG1 test to diagnose rupture of membranes by comparing its performance with the intra-amniotic instillation of indigo carmine in patients with ruptured membranes. And the statistic metrics is given below. So the sensitivity of PMG1 was 100%, specificity 99.1, PPV 96.3, and PV 100%. It means that AmniSure is a pretty potent biochemical marker to rule in or rule out amniotic membrane rupture. Then Ramsauer has performed a meta-analysis and compared the diagnostic performance of an immunoassay for PMG1 in vaginal fluid with the insulin-like growth factor binding protein 1 in the rupture of fetal membranes across different patient populations. What they found out is throughout all patient populations, known and unknown membrane status, the PMG1 test has shown a significantly superior performance in all metrics than insulin-like growth factor binding protein test. They got sensitivity of 96% and specificity of almost 99%. The same author has performed a multi-site prospective observational study and evaluated the performance of tests detecting placental alpha-1 microglobulin and insulin-like growth factor binding protein 1, and they evaluated it in the population of pregnant women with vaginal bleeding as well. What they found is that PMG1 test was significantly less affected by blood admixtures than the insulin-like growth factor binding protein 1. 11% of insulin-like growth factor binding protein 1 tests, but only 2% of PMG1 tests were invalid due to blood. Performance metrics for both of the tests are given in the table below. And it could be seen that there is a statistically significant difference between the both of the tests. And the last slide, PMG1 versus insulin-like growth factor binding protein 1 versus alpha-fetoprotein insulin-like growth factor binding protein 1 in reduction in unnecessary admissions. It was found out that for every 100 women presenting with a suspicion of pre-labor rupture of membranes, AmniSure produced 1 false positive, Actimbrom produced 22 false positives, and Rom Plus produced 25 false positive results. Thank you very much for your attention, and I will be happy if I could answer any of your questions today.
Thank you, Dr. Nikolova, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you would like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. Our first question is, with the ongoing pandemic, what is the risk for the mother or the unborn with the standard therapeutic management you would usually administer?
It's a great question. Precise diagnostic is very important in this situation. We should be pretty much sure who is going to deliver in the next 7 days and who is going to not to deliver. Corticosteroids and tocolytics for 48 hours are mandatory in all cases which are less than 34 weeks of gestation. We should avoid as much as possible a second shot of corticosteroids. And as already reported, a prolonged exposition to corticosteroids is unfavorable for the general population in this corona period. We still do not know the influence of prolonged corticosteroid therapy on the sick corona mother and on her unborn baby.
Okay, thank you, Dr. Nikolova. Our second question is, how can the use of biomarkers help in the preterm labor management during pandemic where hospital admissions are under pressure?
Actually, they could do much because using the biochemical markers, we could decrease admission rates by most accurate diagnostic method. Quick turnaround time, they are easy to use. The confidence in these results is pretty high. These biomarkers this biomarker testing could be performed by residents, by nurses, midwives. The time to obtain the results is very short. We don't need to insert a speculum, and yes, we save resources. We save beds, which is very important in this corona time, patient beds.
Thank you so much, Dr. Nikolova. Our next question here is, when is the best gestational age to give betamethasone, and when should we not give it?
Betamethasone is given everywhere. We should give everywhere when the gestational age is less than 34 plus no gestational week. We should avoid to give it later. We should avoid to give it the second shot or to reduce minimum. When the pregnancy is, when we have a patient which is, let's say, 29 weeks of gestation, it's reasonable that we will maybe repeat it, but we should minimize it. And the biomarkers could help us very much in this triage. So we could be pretty much sure if this patient will deliver or not in the next 7 days.
Okay, we've got another question here. Is it any useful of elastography of cervix during transvaginal cervical measuring? I don't know that I worded that correctly.
In everyday work, I must admit we don't use elastography that much. The published data say that cervical length measurement is more reliable, and then cervical length measurement together with biomarkers could obtain pretty high predictive value. So I don't think that we need to do elastography during transvaginal cervical measuring just to find out if the patient will deliver or not.
Thank you, Dr. Nikolova. We have a few more questions. This next question here. Can the biomarkers AmnoSure and PartoSure be used after vaginal examination?
Well, according to package instruction, package insert, they should be used after 24 hours after vaginal manipulation. But studies have shown that PartoSure can be used 30 minutes after transvaginal ultrasound and right after digital examination with a very high accuracy of 95%.
Okay, now our next question. What is the turnaround time of PAMG1 test?
It's 5 minutes. The test could be done in 5 minutes. 30 seconds, the swab should be rotated in the vaginal cavity, around 30 seconds, then additional 30 seconds rotation in the vial, and then we wait for additional 5 minutes. So in 5 minutes, we could have a ready result. The PMG1 is very powerful to predict the delivery in the next 7 days, but also in the next 14 days. We have analyzed its performance metrics in the 14 days, and we have found slightly worse results than for 7 days. So we could be pretty sure that the patient will deliver and or will not deliver even in the next 14 days.
Okay, looks like we have one more question here. How is the distinction done between the membrane rupture and risk of preterm delivery?
Actually, the patient, if the membranes are ruptured, we should clinically tightly monitor this patient We should follow the inflammation parameters. CTG should be done more tightly. The patient is at high risk to develop chorioamnionitis. The risk of preterm delivery is very high. If the pregnant woman is more than 34 weeks pregnant, she could deliver without huge problems. But if there is pregnancy, if the pregnancy is less than 34 weeks, or maybe less than 32 weeks, the risk is very high. It's very challenging to manage such a patient. Is very challenging.
Thank you, Dr. Nikolova. We do have a new question that just came in. PAMG1 is a biomarker for both PartoSure and AmniSure. Why don't we use only one test for either preterm labor or ROM?
Because PMG1 in form of PartoSure detects a lower concentration of placental alpha-1 microglobulin 1. I have already mentioned this threshold is 1 nanogram per milliliter. When it's more than 1 nanogram, when it's even 5 nanogram per milliliter, it's highly suggestive for rupture of membrane. So they detect the same substance but in different concentration. PartoSure could detect lower concentrations, and AmniSure detect higher concentrations. This is the difference. And I have already mentioned how this PMG1 came in the vagina. It's in the so it's a big it's present in the amniotic fluid in a huge quantity, and then it will be saturated. It will be it comes in the vagina with uterine contractions.
Thank you again, Dr. Tanja Nikolova, for your time today and for your important research. We would also like to thank LabRoots and our sponsor, QIAGEN, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.
Thank you very much.